Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, your host for today. I'm a community pediatrician here in Cincinnati, and I'm excited to talk to today's guests, Dr. Marrisa Vawter-Lee and Dr. Barbara Hallinan, both from the Neurology Division here at Cincinnati Children's. Today's discussion is something that brings us as community pediatricians a lot of stress sometimes, differentiating between benign infants and toddler spells and seizures. So we're happy to have the experts in the house today to help us with this. First, let's get to know our guests, Dr. Hallinan and Dr. Vawter-Lee. If you guys can tell us a little bit about yourselves, what brought you to Cincinnati, how long you've been practicing, and any other interests.
Well, actually, what brought me to Cincinnati was another job at UC that I left to go to med school. And I went to UC Med School and did my combined peds neuro residency from 2001 to 2006, and I've been in attending since 2006, so this is my 19th year.
And I'm Dr. Vawter-Lee. I came here in 2010 for residency, stayed for 5 years, did a 1-year baby fellowship in the NICU on neonatal and fetal neurology, and I've been faculty here since 2016, so entering my 9th year.
And thank you both for joining us today. So, as I said, today's conversation is about benign infant and toddler spells versus seizures. This is the kind of problem that we see on our schedule that the parents coming in concerned about, is my child having seizures? And as a general pediatrician, we want to make sure that we can either provide them reassurance when that's appropriate versus getting our neurology colleagues involved as soon as it's necessary. So if you guys could tell us a little bit about what types of benign spells that we see in infants and toddlers, and then we can talk more about more the concerning types of spells.
Yeah, I'm happy to cover the benign ones. So we actually have a clinic just for this, and so we're 2 of the 3 people, and that's because baby spells are so common. So it's not unusual for parents to be bringing up these concerns. Babies just do tons of quirky things, and sometimes you just have to look at it and watch it and see how it plays out, and then other times we look at it and we're like, no, that's something to be a red flag. So the benign ones that I don't worry about that are common, I think the most common one that pediatricians see are breath holding spells. Mm-hmm. So these little rascals, they get upset about something, they get angry about something, sometimes they cry, sometimes they don't, and then they hold their breath. And they will hold it for a really long time. And then there's 2 types of the breath holding spells. There's the pallid, where they hold their breath and just get deathly pale, and they look like they're dead to their parents, and it's scary for those parents. And then there's the cyanotic, where they get bright blue and purple in their face. And either way, they will hold their breaths for 30 seconds, 60 seconds, and then something will get them out of it, and they will take a breath, and they're okay. But it's scary for the parents, and these kids look stunned afterwards. So breath-holding spells are just so common. We're always happy to see those kids, and you can treat that with iron supplementation, and we know that those spells really lessen in frequency.
And once you have a kid does this, does it tend to happen again and again with that same child?
Yeah, that's the hard part for these parents. Once you have a breath holder, they're a breath holder, and they love to do it. And the funny thing is sometimes it runs in families. And so grandma will show up and be like, oh, your dad did that. And so it's just funny. It seems to almost be like a personality thing. These kids are just so stubborn. And before they have the language and vocab to yell at you and tell you, no, I don't want to do that. I want to play with my toy. Or no, I don't want to turn off the TV. They'll just clamp down and hold their breath. So parents get really crafty with those. Along with iron supplementations, I sometimes have parents do ice. I've had parents give candy to the kids, like just whip the candy bag out of your pocket, and we'll try all kinds of stuff. The one thing that's a little frustrating with breath holding spells is if you hold your breath long enough, sometimes those kids will go into a provoked seizure. It's really rare, probably less than 1% of the breath holding kids.
It seems like of the population that gets referred to us, probably more, because that's why they're being referred, because they're having jerks afterwards or doing something, even a staring spell afterwards. So, yeah, probably all comers is probably very low, but the referral bias to us is higher.
Yeah, and so we have to explain to those parents, like, that's actually a benign breath-holding spell. I know they had a little shaking after that, but that's not that's not a true epileptic seizure. They're going to outgrow these. And so we know breath-holding spells go away after 6 months, 12 months, usually by 3 to 4 years old. Kids have totally stopped doing that.
I think for us, for seizures in general, we tend to say, is it a seizure or not? And then is it provoked or unprovoked? So when it falls in that provoked, like by breath holding or fever or febrile illness, then that's more benign. That falls into the more benign category.
And then what are some of the other benign spells that we see?
Shuddering spells is a good one. I feel like that's another one that grandmas know about. So, sometimes when kids are nursing or taking a bottle at night, especially as they're falling asleep, they'll have whole body tremors. They can look very seizure-like. I don't know if you want to talk more about that. Sometimes if the kid wakes up, it'll go away, but it's a whole body tremor, so it's very scary looking, but it's actually benign.
Or they can even be wide awake playing, and it'll look like they just get the chills. Like they'll be sitting there and just for like 5 seconds having this intense tremor. But they're never post-ictal afterwards. They always go right back to normal. During it, their eyes are open and they're looking around.
Are they usually pretty brief like that?
Short, yeah,
A few
5,
seconds.
10 seconds.
But they can happen multiple times, and I think that worries a lot of parents.
And I get asked a lot of similar spells right when babies fall asleep.
Yeah,
or as they're sleeping, they check on them in the bassinet and they see them shaking for a few seconds.
The sleep
Is that a
myoclonus.
similar? Okay.
Yep.
Yeah, so there's benign infant and there's benign neonatal sleep myoclonus. Those can be wild as a parent. And YouTube actually has some great videos that I sometimes will pull up in clinic and show to parents and be like, is this what you're describing to me? And so those are our newborn babies. The myelin just hasn't, I think about them as the myelin connecting your brain to your spinal cord and your nerves hasn't fully formed, and so their movements are just a little uncoordinated. And so sometimes they do quick myoclonic jerks. You can tell it's not a seizure because it's not rhythmic. It's one side, then it's the other side, it's an arm, then it's a leg, then it's all four at once. It just never is stereotyped. It looks so different each time, and they're rapid. Again, not rhythmic, no beat to it. But it can be wild as a parent. It's like jerk, 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 and then they'll stop. The way you can reassure yourself as a parent is the baby is clearly asleep, or they are eyes open but super drowsy, and you can tell they're about to fall asleep. So I tell those parents, if you look at it and you're not sure, just pick them up.
Right, wake them up.
If you wake them up and the movement stops, if you strip off their clothes and the movement stops, you know that was sleep
And really
myoclonus.
wake them up, not the drowsy
Yeah.
state like you're talking about, because we do get reports, well, his eyes were rolled back. Well, that's because he's falling asleep. He's still drowsy. So
Gotta wake them up. And I always tell those parents, like, if you wake them up and it doesn't stop, and then I want to know about it by all means, but 99% of the time it stops right away. We do admit patients for that, though. It's one of the things we even see on inpatient, because sometimes sleep myoclonus is just so wild, especially to first-time parents. It can really catch their eye.
And I think sometimes pediatricians are kind of in the position just where we are. We have a big children's hospital, so the parent will want the referral, even if you know what it is. You know.
Oh, yeah. We get that quite a bit, which is, and you're always very, very helpful. And sometimes hearing it from an expert carries a little more weight, but then they can come back to us and we can keep an eye on them. So that's great. Any other common presentations that you see?
Yeah, I think there's a couple more things. One of the most common referrals we get is for staring spells.
Okay.
We see tons and tons of staring spells, and not so much babies, but toddlers. They just like to look off into the distance and think deeply about things. And so if you're a parent and you put that into Google, it says it's an absence seizure.
Yes.
So we always tell parents, number one, absence seizures don't really start before 3 years old, 3.5 years old. So you can feel the odds are in your favor. And then there's a couple things you can do as a parent to rule out like the really rare instances where an absence seizure would start in a baby. And those are, you can try to stop it. And parents are very nice people.
Yes.
In general, parents are like,
Stop it like a neurologist
Yes.
would try to stop it.
I always say that. I say stop it like I would. I'm mean, guys. So don't be nice. Don't say their name. Don't gently touch their shoulder. Don't call them from a class, across the room. Don't snap your fingers. I tell them you have to get in the kid's face. You need to either pinch their armpit, pinch their knee, or you need to tickle their eyelashes. And if they blink, if they pull away, if they start crying, if they look at you, you know it's not a seizure. You know it was definitely not an absence seizure. You know it was them just dazing off into la la land.
Okay.
And that's just so common. Honestly, that's probably like 25% of new referrals I get are these staring spells. And as a parent, it's just so scary. But nine times out of 10, I tell the parents, pinch them for me, tickle the eyelashes, and a week later the parents call me back and they were like, you're right, it stopped immediately. I'm not worried about it anymore. So.
And then repetitive movements, like either tics or stereotypies, or stereotypies. How do you guys say that?
Stereotypies.
Stereotypies.
Okay, I've heard it both ways, so we'll go to the
And the
expert.
classic is like a kid who's very excited, so his arms are flexed and stiffed and kind of trembling a little bit. That's classic. Parents worry about stereotypies, even if they know they're stereotypies, because the first thing if you type that into Google, you'll run across autism. And plenty of kids have stereotypies that don't have autism. It's a pretty typical behavioral thing that kids do.
I had that conversation in the office yesterday. Like a 2-year-old, and I say it's just he's so excited, it's coming out of every pore of his body. And he's just shaking and flapping, but he's otherwise socially developing normally. So just how they are.
I always tell parents 99% of stereotypy kids are just normal kids. It's only 1% that are going to go on to have autism, but 100% of kids with autism have stereotypies. And so that's why if you look on Google, it's so scary as a parent.
Mm-hmm.
Yeah.
The hand flapping, a lot of shoulder stuff, eye fluttering, eye blinking stuff.
I stole
Body
Don
rocking.
Gilbert's movement disorder little blurb on stereotypies and modified it. That's what I give parents to say, just to reassure you, it's not a seizure, it's not a tic, it's just a behavioral event that will eventually outgrow or invent new, very complex ones.
And some of them can be really distressing for parents. Like there's one particular variant where people do a lot of head banging as their stereotypy. They can do it in their crib at nighttime, and that's really distressing as a parent. And those are normal kids who, again, once their communication skills get better, they do great. The red flag for me with stereotypies is if their development's not normal. That's when the parents and I start to really dig into that, especially language like you guys would in the pediatric office. And those are the kids who I'll pay attention to. But most time I just say like exactly what you said, Dr. Bunch, like this is a sensory thing. Their body's just figuring out stuff. They get really excited and they've got to get that energy out.
So there are a lot of normal and benign movements that we see like this, and we can reassure our parents. I think some of the tips and things to ask really are helpful. But there are going to be those kids that come into our office who have more concerning symptoms. What kind of things get your attention as far as epilepsy, seizures, infantile spasms, those things that are always in the back of our mind? What kind of questions do you ask, or what things do parents tell you?
We're always on the lookout for spasms. So I always appreciate a referral where the pediatrician has described the event, because sometimes it's just events of concern. Because one thing you may not realize is we actually triage all of the referrals to our infant clinic, so that's ages 2 and under. So we're looking at that to see, should we get an EEG ahead of time? Should we see them sooner? So we're using that information. So as much as someone can put in the referral about the description of the event, the better. So
yeah, I agree. I don't know if that would surprise pediatricians, but if you write down spells,
Yeah.
I'm like, what does that mean? But if you put a description, we will triage much faster if it sounds worrisome.
And if I can find the clinic, note, if it's someone local, sometimes I can see that. I'll do my best to try to figure out what it is. But febrile seizures might go in one category if they're a certain age. But for spasms, we're looking at kids who are still usually in the first year of life. Usually around 6 months. There are certain predisposing conditions we look for, like Down syndrome. And so over the years, we get a lot of referrals from the Down Center here, or DDPP. We'll get a call from someone, and we try to get those kids in with an EEG pretty soon. And the reason is the EEG will sometimes be abnormal even when they're not having a spasm. And so that's a very good triage tool for us to see how fast we need to get them in. So.
And the thing with spasms that you would hear as a pediatrician would be the parents would be telling you it's a cluster of spells. It just started yesterday, it started today. It's when they're waking up, it's when they're falling asleep, those sleep-wake transitions, and it's the same movement. With infantile spasms, it looks either like a baby sit-up, so they're flexing their head down, they're flexing their arms and their legs up, or the opposite. They flex their head down and then they kind of extend their arms and their legs out. And they do that for a quick second, they relax, they do it for a quick second, and they relax. And a spasm cluster will be, sometimes it's a minute long, sometimes it's 5 minutes long, where they're doing that movement over and over, and they'll do that cluster, and then the next time they go to take a nap, it'll happen again.
Okay.
And so if you're seeing that would be a reason to pick up the phone and call us, because we're probably going to bring them to the ED.
Okay.
9 times out of 10, we're going to want to admit them right away to evaluate for that. I think other red flags that you guys would see would be any spell that's coming out of the sleep-wake transition with the eyes fixed wide open, no blinking. Parents are telling you, I pinched them, I tickled them. They continue to have their eyes staring. Any rhythmic jerking that the parents can't stop when they touch it. Eye deviation, like eyes forced to the side. Mouth movements, like rhythmic lip smacking. Those are the kind of things that would catch my eye.
I think that's very hard in young infants who tend to have, little baby tremors and things like that. The idea that you can suppress it, I'm not sure that, to a parent, they're feeling that vibratory feeling and that may not be suppressible to them. So, but to a pediatrician, I think you know more what we mean. If you see it happen in front of you and you can distract them out of it or stop it by changing the position of the infant, then it's probably not a seizure.
Okay.
But we're still happy to see them.
Sure.
And then I think the other thing for me that's a red flag would be if the kid is a setup to have seizures. So a baby who had a rough delivery, a baby who, has an abnormal brain, a metabolic or genetic condition. That's somebody who you've got to have a higher threshold. And that would include kids who you've already diagnosed with autism in your clinic, because we know that in autism kids there's a 30% chance they're going to have seizures at some point.
Okay.
So if someone's got that kind of background history, we would want to triage them much higher because we'd be worried.
So if we get a call from a family saying, my child's having these abnormal movements, often a video is going to be very helpful.
Yes.
Do you have any tips to help parents to capture these things on video? Because sometimes you'll say, I'd love to see a video of this, and they say, well, it happens so randomly, I can't ever catch it.
I think that's tough. A lot of times we get videos of kids in their high chair because I feel like that's a captive audience. You're right in front of your child, you're feeding them, or when you're putting them to sleep, rocking them, something like that. But if it does happen very randomly, sometimes they can. I know we always ask parents to do that, and I'm like, would I have thought of that as a young mom? I don't know, whip out my camera.
Yeah, I always just have parents act it out for me if they
Yes,
have a
if they
video.
can.
Okay.
And parents are usually nervous and embarrassed. I'll be like, no, seriously, let's just act this out together. Did it look like a tremor? Did it look like rhythmic, GTC stuff? And then I'll show them demonstrations of different movements, and I can usually tease out pretty accurately what it looked like.
Is there any other information that parents can bring to the table, or things we should be, having them look into further before they see us or see you?
I think family history. Sometimes, they may have had febrile seizures as a kid, so that's helpful to know. Like we said, genetics. These days, a lot of kids, if their development is abnormal, genetic testing is so widely available now, more than it was even 10 years ago, that we often have a diagnosis. But if you have a kid who you suspect has seizures, has abnormal development, we'll probably have some genetic testing in there. So some may have already been to genetics for that reason. So if they've gone to Children's, we'll have that information, but that's very helpful.
So sounds like if we have a child that we're concerned does have an unprovoked seizure, seeing their local neurologist, a local child neurologist would be their next step. If we have a kid who had a provoked seizure, it was a post-contact seizure after they fall, if they have a febrile seizure, a simple febrile seizure, how would you advise a community pediatrician how to respond to that? Do they have to see a neurologist? If we're very confident that it's a febrile seizure, simple febrile seizure, can we manage that and provide reassurance? Kind of what would you tell the community pediatrician about those?
I think absolutely. That's within your scope of practice, particularly febrile seizures. Sometimes parents, I think, for like the post-concussive, I fell out of the high chair and nailed my head on the floor and then I had a short seizure. Sometimes those parents will want to see us to be reassured. But I think even that's within the realm of what you guys know as pediatricians, because those are usually one and done. With febrile seizures, though, I do always warn the parents, even with the simple ones, I think the most important thing is to say, hey, they've had one, there's a 30% chance of number two.
That's right.
And if we have number two, there's a 50% chance of number three. And if that happens, there's a 80% chance of number four. Just because those are the parents who sometimes were like, I know they're all simple, but maybe we do want to talk about meds and different options. But those, febrile seizures, if they're simple, don't need an EEG. They don't need an MRI unless there's something else going on. They can really just be watched.
Great. And then when we have the kids that we are referring to you guys because they have some sort of concerning red flag, is there any workup or imaging or EEGs, blood work, things that we can do ahead of time?
Well, I think because we triage the referrals, like I said, so usually I'm making that determination at the time. I'll go ahead and order an EEG just because I know it'll come to me and I'll see it. And I would never dissuade someone if you feel strongly about it. And sometimes I order unnecessary EEGs. I find out when they come in, they're eye rolling episodes. That's another benign thing. So you don't have to, but if you wanted to, there's no problem doing that. I'm more anxious if the question is spasms to see the EEG even before I get them scheduled. So ordering that could be helpful.
And I think if you talk to us on the phone about explosive onset of spasms, again, we're going to say come into the
Yep.
ED and we'll do it all inpatient. The staring spell toddlers, I will say if you tell a parent to try these things, pinch them, tickled eyelashes, and the parents are telling you, they didn't respond, that can be really helpful for you guys just to order a routine EEG.
Okay.
Because you can know as the pediatrician, if you get a clean 30-minute EEG back that's normal, those are 99% sure not seizures. So I think that can be really reassuring to you and to the family while you're waiting to get the kid into neurology.
Mm-hmm.
And Dr. Hallinan, you've brought up, these are the kids we send right to the ED. What situation did you say, don't even come to see us, or if they're in our office, call squad or go straight to the ED? Who are those kids?
I think, over time, I think our pediatricians have done a great job on sorting out who needs to go to the ED right away. You see a patient seizing in front of you, you're going to call 911. I think anything that's very frequent, I hate for kids to sit for hours in an ER. That's the thing. So if they're not doing whatever they're doing very frequently, they're going to sit there because it's a triage system, right? So I think, getting a referral to us might be more, for infrequent events. But if there's something happening daily that we know we can capture on an EEG, or we can review a video of it with you that maybe the parent has sent you, that might help us triage better. Do we need to admit them, or should we just, bring them into clinic? But either way, I mean, if you're feeling like you need to send the child to the ER, I'm fine with that.
Yeah, I agree. I think one reason to send them to the ED is if they had a seizure, you've put the referral in, and the clinic appointment's not for 2 weeks, and they're calling you at your office saying, hey, I think they just had number 2 and number 3, just send them to the ED. We need to evaluate faster so we can get meds started.
So infantile spasms definitely is one of those things we're always on the hunt for, always worried about. Can you guys talk a little bit about how frequently we see infantile spasms, and then maybe a little bit about current therapies that are in use?
It's supposed to be rare, but we're a big referral center, like we said before. So Marrisa has a factoid here that we see 30 to 40. Does that include our tuberous sclerosis population?
That does not include those.
So I know last year was a banner year. I was averaging like 14 in my clinic a year, and last year it was 20. So, I mean, people are either aware or a referral base. I feel like we're getting more referrals from outside of the tri-state area. And so, yeah, I think we see quite a few. So that number is probably even higher if I saw 20. I don't know how many you saw last year.
Probably the same.
Yeah.
So, yeah, probably 30 to 40 within the community group, plus tuberous sclerosis causes infantile spasms, and we manage those a little differently. They have their own clinic for that.
Mm-hmm.
And then our NICU graduates, people who had birth injuries, like HIE, some of those kids specifically, depending on MRI, are very high risk, and so they just are seen outside of our infantile spasms clinic, and I follow some of those kids too. So it's way more frequent than you're taught in med school.
Yes, it feels that way.
Like, I know for a city of 1 million, we should have like 5 a year, but we consistently see 30 to 40 a year here.
Yep. And I agree with you. That's another thing on the referral. If it's history of HIE and they're 4 to 6 months old, I'm going to get that kid in as soon as we can, if not admit them.
And then as far as treatment, how are you guys taking care of those kids these days?
Well, ACTH is my preferred first-line medication. A lot of places still offer a trial of oral steroids for about 2 to 4 weeks. My issue with that is always you're going to create the same side effects, and unfortunately, a lot of our referral base is probably 50% second and third opinions for treatment of spasms, and so they're steroid failures. So there are those kids out there who do respond to one course of steroids, but if they have some other genetic factors, sometimes I'm just hesitant because I can't sort them out ahead of time. Who's going to respond to the oral steroids? And we also like to do this in combination with vigabatrin. And it just kind of depends. There's some kids who have cardiac conditions. Usually the cardiologist is on board with whatever we suggest, but we like to clear it with the other subspecialist involved with the child's care. And but that's basically what we do, is ACTH plus vigabatrin.
Yeah, and it's a month of ACTH shots, and then vigabatrin is 3 to 6 months, just depends on the kid. And ideally that works, and we're off of meds at 6 months later. If it doesn't work, then 2 weeks after we start ACTH, we're making changes. There's other meds we'll use, like zonisamide or Zonegran. We'll talk about the ketogenic diet. There are other things we can talk about.
And there are some kids who have underlying metabolic conditions that, for instance, might require the keto diet, so we know that's in their future, or there's other drugs based on their channelopathy that would be good for them. But spasms is kind of an odd bird because it's kind of a final common pathway of a lot of things, and so you have to get over that hurdle really to use like drugs that are specialized for that child, or even the keto diet for it to work. So, and we actually look at what we consider success is the spasm stop, and the EEG pattern reverts to either the baseline or is normal, and that's at the 6-month mark. So a lot of the literature, my frustration with some of the literature is the patients aren't followed very long, and so they'll say this stops within the first 2 weeks. Great, but it's a treatment failure to us if they reoccur within 6 months and the EEG pattern is still hypsarrhythmia or some other abnormal pattern. And I think the other thing I've noticed in our second opinion referrals, some places will not treat a child unless the EEG pattern is this very chaotic hypsarrhythmia. Hypsarrhythmia is actually not required for the definition of infantile spasms, and so I think they get caught up, and then, time is brain, so it's really important to treat it early. You're more successful if you can do that. So that's, we kind of get in there and treat just very aggressively, very quickly.
Yeah, I find that parents are great. Parents have great intuition for infantile spasms. It is not uncommon. They have the cluster at 5 p.m. and they're in the ED at 7 p.m.
Okay.
Like, parents sometimes they know. They're like, that was not normal. And
Yes.
more and more parents are like, I read on Google about my kid's spell and I think they have this. And I'm like, well, you were right. So,
Yes.
But yeah, we have a protocol we follow here. And I think a lot of other places, like Dr. Hallinan said, will do oral prednisolone first and then do vigabatrin or ACTH second line. So we're a little unique in that we do combo here.
And the reason is, and we're very lucky to have all the resources we have, including fantastic care managers, because the insurance process for obtaining ACTH sometimes can be very, very difficult. And I think this is that, along with the monopoly that some companies have had on it and the jacking up the price. I think this is why a lot of folks don't want to use it. But unfortunately, it works, so we always get what the patient needs, and we're just fortunate we have the resources to do that.
Thank you guys for all of this good information. Any last pearls of wisdom that you'd share with people who take care of kids, community pediatricians, family practice physicians, nurse practitioners, for helping parents navigate this complex topic?
I think videos are your friend.
Yes.
The more videos you can show to the pediatrician, the more they are able to figure out. Pediatricians know when they look at videos usually what's going on. And then we really do read your referrals.
Yes.
So write on the referral what you're seeing, because we read it, I promise.
I agree. Yes.
Well, that is all wonderful. Thank you guys so much. As a reminder to our listeners, today's episode is available for CME. You can find the link in the show notes. And today's discussion was guided by the Cincinnati Children's Community Practice Support Tool that you can find at cincinnatichildrens.org. Thank you, and have a great rest of your day.